Welcome to the 6th Annual ARC Summit. I'd like to first of all welcome everybody that flew in. Of course, we have international visitors with us today, all of our speakers, our distinguished guests, and we have special guests also with us. We have 5 IVF families that are here with us today. Our IVF coordinator, Courtney Shepard and Johnny Flores, welcome. Local OBGYN, Drs. Anita Qasim and Mr. Suleiman Orquiza, welcome. Rita Youssef and Alberta Daboul. Dr. Naveen and Shaila Karanti, welcome. And 2 local RNs also, Christina Pages and Matthew Pages. I'd like to welcome all of our IVF families. Like we say, our success is measured in heartbeats, and we'd like to welcome you for being here with us today. I'd be remiss if I didn't also thank all of our sponsors for helping contribute to this summit, the 2025 summit. You'll be hearing from some of them during our lunch break also, and this evening, so we'd like to thank you also. It's been an interesting year for American Reproductive Centers. We've had our shares of ups and downs, challenges, setbacks, and through it all, we overcame it as we promised. Our commitment to our community, to the medical practice, to our employees, and of course, to our patients. We will continue to grow, God willing. We will continue to thrive. We will continue to innovate, and we will continue to have these amazing gatherings with all of you here to continue to share and grow all of our medical in this medical space. Our promise to our community, our patients, and our colleagues remains unwavered, and today is a testament of that. I'd like to thank you all for your participation in this event, and as I was talking to a couple of our colleagues here earlier and doctors, the event continues to grow year after year. Many of you are returning guests with us. We'd like to welcome you for coming back and thank you for your continued support, and this will continue to grow. It will continue to blossom. It will continue to bring in people from all over the country, internationally also. We have an international speaker here with us today, and we'll continue to share all of the best practices and technologies moving forward. The goal here today is really to gather everybody together and our elite leaders in our field to share and educate best practices. That tradition will continue today. We're looking forward to so many great speakers. And I just wanted to kind of touch on the itinerary before we began with our first speaker. We'll have back-to-back speakers, about 20 to 30 minutes each presentation. After our 4th speaker, we'll have a 10 to 15-minute recess where you can get up, walk around a little bit, have some coffee. At 12 p.m., we'll have our lunch break, and it'll be right here in this room. You'll hear from 2 of our sponsors during lunch, and then we will commence. We will continue our speakers, and again, after the 4th speaker, we'll have another break, and then we will conclude with Dr. Abdallah closing out this afternoon. And then at 6:30 p.m., we'll all get together with our families and friends and break bread at Mastro's at 6:30 p.m. So with that, I would like to bring up our first speaker. This is his 4th year speaking. He's joining us from Stanford University. He is the previous division head of reproductive endocrinology and infertility at the University of Louisville. He is currently a clinical professor in obstetrics and gynecology and REI at Stanford Medicine. Ladies and gentlemen, I'd like to bring up and welcome Dr. Steven Nakajima. Doc, thank you very much. Welcome. You're very welcome. John, you got him?
Well, good morning, everyone. All right. Let me introduce myself. I'm Steven Nakajima. I'm one of the reproductive endocrinologists at Stanford. It's really an honor to be invited back to Dr. Abdallah's seminar here. I think I was at the first one originally, and it continues to grow as you've heard. It's just a wonderful event. Here I have a few disclosures. So I'm a busy practicing REI at Stanford. And then we contributed to the NatPro study that compared natural to program cycles. And so we'll talk a little bit about that. I'm also the chief science advisor and co-founder of a company called Butterfly Biosciences. It has an interest in uterine lavage and embryo transfers, but we're not going to talk about any of the things that we're going to be doing with that company. And as you heard, I was the REI division chief and fellowship director for at least 3 of our fellows here. Mahar Abdallah came to us from the Bronx in 1998. Paul Lynn, who was here the previous year, and then Abby Eblin, who I got to be the fellowship director for the last 3 months of her fellowship, and then she was faculty with us at Louisville. As you'll see, there's this overriding theme of being connected to the University of Louisville, and you'll see that throughout today. And then I want to just appreciate the support from Joe Sanfilippo, who was the previous director and helped me get my position at Louisville. That was back in 1997. Had a 15-year run there, and then recently been at Stanford the last 11 years. So today what we're going to do is we're going to ask you, or try to answer for you, this question of interest. And that is whether natural cycles might be a good substitute for program cycles, which is done primarily throughout the United States. And this talk is an outgrowth of something Mahar and I talked about last year. He goes, "Oh, what do you want to talk about next year?" And I said, "Well, I could talk about natural cycles." Natural cycle, yeah, I'd like to hear about that. So I said, okay, we'll put it together. So in the outline, we're going to talk a lot about the human menstrual cycle because that's really the template by which we're going to really act upon. And then I'm going to talk a lot about natural cycle, and I'll show you some of our patients and what they've done. So worldwide, there's about 1.6 million cycles of ART performed every year, and about 500,000, 500,000 cycles are frozen embryo transfer. And what's been observed over the last couple of years, maybe last 10 years, is that FET has been associated with an increased risk of preeclampsia. And it seems like there's a greater risk for preeclampsia to occur in women that have had a program cycle than a natural cycle. So for women that have ovulatory cycles and are going on and having their own menstrual function, which one should they really choose? So if you look here, I've compared the 2 types. Natural cycle uses the ovary's own production of estrogen from a single follicle usually. And then we usually do 2 to 4 periovulatory ultrasounds, and we do a fair amount of labs. We do E2, LH, and P4 levels right from the first day that we usually see them because we want to know where they are in their cycle. And we're really trying to nail down where they are. Because we're following the natural cycle, you're going to have a variable day that you're going to transfer that person. So you have to be able to do FETs 7 days a week. And then we're going to augment the natural cycle. So although it's called natural cycle, it still has a little bit of augmentation. And we augment with vaginal progesterone for 8 weeks. And we start 3 days after the trigger or 2 days if you're on your LH surge. The negative of this is it's more expensive. It's going to have more visits and a little bit more challenging. Sometimes there's a little bit of a learning curve that goes with this. I'll tell you, when I left Louisville in '98 and I came to Stanford, I had never done natural cycle. And then, so I was really kind of a neophyte in this area. So I had to learn how to really get used to this natural cycle because the clinicians there were already using it pretty routinely. And I got more and more enamored with it because, as you'll hear from my fellows and my residents here, that I'm really a lover of the menstrual cycle. I mean, I think the menstrual cycle is so cool. I mean, when you think about it and how it works. So so this just builds upon my love of the menstrual cycle. Okay, so in comparison, program cycles are, we take that woman, even if she's ovulatory, we'll go ahead and give her high-dose estrogen. This is one version we use we used at Louisville, and I use it at Stanford. We use oral estrase, 2 milligrams 3 times a day. We do it for 2 weeks or so. It's fewer ultrasounds with minimal labs. We maybe get 1 or 2 labs just to kind of check that the lining's reasonably thick. and that progesterone hasn't been started from an occult ovulation. You can choose the frozen embryo transfer day. So a lot of clinicians and a lot of big practices, this is what they do. They never transfer on the weekend. They only transfer Monday through Friday. That allows them to do staffing and maybe less people that have to come in on the weekend, especially for smaller practices. This might make a big difference. And so you administer the either daily progesterone or vaginal progesterone with intermuscular progesterone and oil. We like the combo because most of our patients don't want to do daily progesterone and oil, and it's less expensive. So because it's less visits. So that's the quandary. Is it really that important to use the corpus luteum in a natural cycle when you have that available? Is it worth it? Okay, so as I mentioned, you really use as a template for this the human menstrual cycle. And so I'm going to go review with you the steps involved in the human menstrual cycle. And like I said, I have this real love for this cycle. So, all right. So the way the human menstrual cycle starts is that you have a gland at the base of your brain called your pituitary gland, and that's being stimulated by a higher center, the hypothalamus. And there's secretions of GnRH pulses that occur about every 90 minutes in the follicular phase. This elaborates secretion of LH and FSH, which travels to the ovary, and then you get development of a dominant follicle, and the dominant follicle produces estradiol. Estradiol is a perfect marker for ovarian function because about 95% of all the estradiol comes from the ovary and the granulosa cells. So, the ovary is very dynamic. You're losing eggs every day of your life, and when you're a woman, that's after you start your menstrual cycles, it's estimated you lose anywhere from 500 to 1,000 eggs every month, and it's only the eggs that see a certain amount of FSH, about 3 or 4 days, that exceeds LH. It's the only time in the whole menstrual cycle where FSH exceeds LH that you can capture some of the follicles that would be normally undergoing local atresia. So when you get a critical amount of FSH present, then you can select a dominant follicle, and it starts to develop, and then it eventually ovulates and forms a corpus luteum. Corpus luteum has a timed lifespan. It's because the GnRH pulses start to decrease in frequency. You withdraw support, and the lining and the corpus luteum only lasts for 2 weeks. So when you have a corpus luteum, it's going to start to secrete estradiol and progesterone. It's going to help the endometrium get ready for an implantation event. And as I mentioned, there's this limited lifespan of the corpus luteum. And as GnRH pulses become less frequent, levels of estradiol and progesterone start to fall. And without the presence of HCG, which shares the same alpha subunit as LH, HCG rescues the corpus luteum in case there's a potential pregnancy there in the uterus, and that's what causes the continued production of estradiol and progesterone and from the corpus luteum, and a woman misses her period. Now, I always say to my residents when I'm teaching them the menstrual cycle, I said, when you miss your period, you're either elated because you're pregnant, or you're just horrified because you're pregnant. It's the corpus luteum that's at fault here. It's producing estrogen and progesterone, keeping the lining from breaking down, and you've got a developing pregnancy. And in fact, the corpus luteum continues to function even at term. So I'll throw this out. We can get a free weekend at the Bellagio if anyone gets this answer correctly. How much progesterone is circulating in a woman at term? What's the average level of progesterone? Now, nobody knows this because nobody measures this. But it's about 200 nanograms per mil. And about 20 nanograms per mil, or about 30, come from the corpus luteum. The corpus luteum is still functioning. I mean, I went back and I did all my research on the corpus luteum, so I know this area pretty well. And the corpus luteum is still functional at term. And so the real question is the function of the corpus luteum at term, that continued secretion of progesterone, estrogen, and all the other peptides it makes. It makes one peptide called relaxin. And relaxin might be really critical in this whole genesis of pregnancy-induced hypertension. So that's kind of the background, the physiology. All right, so the next graph I'm going to show you, this is a reproduction of the menstrual cycle by one of my second-year residents. This is Jocelyn Ray's production. She did this about 10 years ago. Jocelyn's now a GYN oncologist. But as my residents will tell you, Steve Kang's here and Susan Shondell's here. You might remember doing this, but I usually give the residents a blank piece of paper and I say, okay, you got to reproduce the menstrual cycle. And you got to do it with the units, and we want to be able to see the differences in the hormones and to teach them, how the hormones fluctuate. And some of my residents get really involved. They bring their own graph paper, they bring rulers, they bring everything, different colored pens. This has really become quite a tradition that I've actually continued. I started it when I was at Davis, and then I took it to Louisville, and then I still do this every day with my residents at Stanford. So the key events really in the menstrual cycle is you get this increased amount of FSH to stimulate these eggs. And sometimes if you're older, you're making lots of FSH to bring up these eggs. And so this is the diagram, and here Jocelyn did a really good job of showing exactly that FSH is the only time in the whole menstrual cycle that FSH exceeds LH. And in doing so, it then go ahead and captures some of the follicles that would normally be undergoing atresia. And so that's why the follicular phase gets shortened in women as they get older. When I mean older, I'm not trying to offend anybody here, but when you're about 35, you're reproductively older. And so what happens is you make more FSH to bring up that older egg, and you shorten the number of days in the follicular phase. And you go from maybe 14 days to 12 days, 11 days. And this is why women start to shorten their cycle length when they get to be 35 and above. They go from 28-day cycles to 26-day cycles to 24-day cycles. And this is also why women over 35 have a higher chance for spontaneous twinning, because they're bringing up more FSH to bring up this older set of eggs, and sometimes they ovulate too. So, and then what happens is you have to have a critical amount of estradiol to actually lead to an LH surge. You need 200 picograms of estradiol to be circulating for 40 to 50 hours to see positive feedback to make this huge amount of LH that you're going to go ahead and that's going to cause you to ovulate. I mean, this is something that's so fascinating. I mean, think about it this way. LH only has a half-life of 20 minutes. And how can it accumulate to such a high degree that it exceeds the FSH level? It's just tremendous how much higher it is. LH is, because we measure daily LHs in these women, it's not uncommon for us to get an LH level of 42 or 50 or 60. Hugh's nodding his head because he's seen this. It's just remarkable. If you measure frequently enough, you can pick people up on their LH surge. And then we usually try to interrupt it. Again, this is not true natural cycle. If we have a dominant follicle and it's over 18 millimeters and we have a thick lining that's over 7 millimeters, we'll go in and affect the change, and we'll give LH in the form of an HCG trigger and go ahead and affect that, make our own surrogate LH surge. And then we'll transfer 7 days. If you're on your LH surge, though, we will go ahead and we'll move up the transfer to 6 days. But again, you've got to be able to do 7-day-a-week transfers. So natural cycle, frozen embryo transfer. This is how we do it. We scan the ovaries for the development of a dominant follicle. We're going to utilize all the hormones that you're making from this natural cycle to be the base, knowing that there could be some variability, and we check daily estradiol, LH, and PF4 levels. We trigger or augment the dominant follicle. We do add supplemental progesterone. We use endometrial, 100 milligrams twice a day, 2 to 3 days after the trigger, depending on how high your LH level is. And then we transfer a thawed, previously frozen blastocyst in the uterus 6 to 7 days later, depending on the patient's LH level. Okay, here's some of the guidelines. We think of a dominant follicle as anything over 14 millimeters. That's when we start to be concerned. That's the follicle that's going to ovulate. We know from many years of ovulation induction that follicles grow 2 millimeters a day on average, and that the dominant follicle from a natural cycle might spontaneously ovulate when the diameter is about 18 to 24 millimeters, and the range in estradiol is anywhere from about 250 to about 450 picograms per mil. We define an LH surge as occurring when the LH is greater than 20 milli-international units per ml, and it has to be quite a bit higher than 20. It can't just be 21. It's got to be 25 or greater usually. And then we want the lining to be at least 7 millimeters. I know that might be kind of risky for some people in the audience because they might want an 8 millimeter lining, but it's amazing how thin the lining is on some of these women. And so we'll accept a 7 millimeter lining. And then there's going to be some natural variations within the given patient. When we do it from month to month, we recognize that, and it could be different between patients. Okay, so what I'm going to do now, I'm going to make this interactive. First lecture of the morning, want to get audience participation. We're going to ask you how you take care of these next 5 patients. Okay, I'm going to give you examples. So the first one is the 37-year-old woman who has cryopreserved blastocyst. We're going to do natural cycle frozen embryo transfer. And look at the date. This is 10 years ago. This is one of the first patients I used to take care of, and I really started to learn how to do natural cycle. So on cycle day 12, her lining is 6.2. She's got a triple line. She's got a dominant follicle of 15 millimeters. Okay, I can ask my former fellows questions like this. I won't ask anyone else, but Mahar. Okay, no pressure here. Okay, what are you going to do? What do you want to see her the next day? Now, Mahar, I don't think you're doing any natural cycle, correct? Yeah, of course. Perfect. You're the type person that don't have any biases. You just, okay. So what would you do? Would you see her the next day?
Yeah, I think I would see her the next day.
Of course. That's right. Right answer. Good fellow. When Mahar came to me in fellowship from the Bronx, I go, oh, wow. I hope he comes back. Because, he's so homesick. He loved the Bronx so much. And I remember when the Y2K was here, remember that, 2000? And Mahar was at Times Square on January 1st. And I thought, he's having such a good time. I hope he comes back. Just please, please, please. Hope he comes back. Okay, so we went the next day. And on the 13th of October, her lining was 6.8, triple layer. Dominant follicles growing 2 millimeters a day is 16.9 millimeters. E2 is 302 picograms per mil. LH is 18.8. When you see an LH that's around 20, anything that's about 10, about 12 or greater, you have to think she's going to surge the next day. So we thought good enough lining because maybe it's a little thin. So what we did, we triggered her. We triggered her with Ovidrel. We went ahead and we did a transfer 7 days later. We transferred a 5AA male. This is 10 years ago. Of course, she got pregnant. I'm not going to show you anyone that didn't get pregnant, right? Be silly. Be silly to be showing you that. Actually, I do have a couple of examples where they didn't get pregnant, but it's just to illustrate a point. Okay, so that's the kind of the basis. That's a typical. We interrupt this cycle, we give you a trigger, we transfer 7 days later. Okay, next patient. 23-year-old, bilateral cystectomies at 23, ovaries are just kind of real fragile. And look at the date on this one. This happened just this year. I actually picked this case because I thought, oh, I really want to illustrate this. Okay, so July 6, 2025, 10 years later from when I started doing this, since I have been at Stanford for the last 11 years, lining is 8, dominant follicle is 16 millimeters. Look at how low her E2 is. It's only 69 picograms per mil, and her LH is 6. Okay, Mahar, next question. What are you going to do? She's got a lining of 8, but her dominant follicle is 16, and her E2 is only 69. Only 69, okay? Hint, hint. What would you do in this patient?
Have her come back and follow me.
Yeah, of course, have her come back. But we might even do 2 days. We might even do 2 days. And so we did. We did 2 days. The lining gets to be the lining is 8.7. It follows 17, or E2 is starting to come up. LH is 12. So again, it could be that she is ready to be ovulated the next day. So we bring her back the next day and look at her LH. Her LH is 31. Her lining is 10.5 millimeters. That extra day gave us a little bit more reassurance she was going to be there. And her E2 was 196. So we augmented her because she's already on her surge, and we gave ACG and her embryo transfer in 6 days. And of course, we transferred this embryo, and again, of course, she got pregnant. Okay. Third example, 38-year-old. Yeah.
When did you give her HCG? That morning, or you told her to take it in the
We tell when they're okay. So we see patients between 7:35, 7:45. Maybe if we're really busy, we have to start seeing them at 7:30. I mean, we're seeing a lot of patients, and we can only ask. We have some 7 a.m., 6:30 appointments too, but not very many. We see them as soon as we have the level. We tell them to trigger. Okay. So like we get our results maybe back at 10:30, 12. As soon as we know that they're elevated, we trigger, and then we go 6 days. Yes.
Can I give my former fellowship director a hassle? Where's the progesterone levels on the last case?
Where's the progesterone level on the last case? You mean
You didn't check them.
on this last case? I think I was. Did I forget it? I did forget it. Okay. I can tell you. I could tell you that it was lower. I can also tell you that, it's really interesting. Progesterone rises very, very slowly. It's usually not more than about 1.5 on that day, but it's about there. Okay. Dr. Lin, you're going to get the next question. Okay, so just be prepared. Okay, so 38-year-old, gravida 1, para 1. This is from 2017. She's got an 8 millimeter lining. She's got a dominant follows 19. Her E2 is 260. Her LH is 45. Do you believe it? And her progesterone, oh, look at that. There's a progesterone on this one. It's 1 nanogram per mil. What would you do, Dr. Lin?
Is it a weekend?
At Stanford, we have no weekends. It's all the same day. We all show up. That's why we have 6 fellows. And there's got to be an attending there all the time, and we're down. I was telling somebody that we had 9 people as of about 18 months ago. We're down to 5, and we are really working hard. I had to fight to get this weekend off again because they wanted me to work another weekend. I go, I don't think I can do that. I don't think I could do that. Okay, Dr. Lin, so what would you do? She's got a LH of 45. She's got a lining that's 8 millimeters. She's got a dominant follicle that's 19. Do you believe it? Or is she PCO? No, she wouldn't be PCO, right? Because she's got regular cycles. So what would you do with her?
I would trigger her.
Oh, you're so right. You're so right. So we augmented her. We said that she's on her surge. We do it 6 days later. We transferred this 5AB female. Of course, she got pregnant. Okay. Next patient. 40-year-old G2, P2. This is 2018. She's got a lining of 7.6. The dominant follicle is 14.6. The E2 is 244. And she's got an LH of 5. Mahar, back to you. What would you do?
Trigger her?
No, I don't think so. The lining is still maybe a little low. Maybe she could go a little bit further. Her LH is only 5. Let's go another day. So we see her the next day. Her lining is 8.2. Her dominant follicle is 15.7. Her E2 is higher, or about the same, plateauing. Her LH is 8. Trigger or another day? Okay, another day. We see her because we want the line to be even thicker, and her LH was low. Her LH is 17 now. Her lining is 16.7. Her E2 is 435 picograms per mil. Her progesterone is 0.3 for Dr. Lin. What would you do now, Mahar? Okay, so you're going to trigger. We triggered. That's exactly right. We triggered. We went 7 days. We transferred this female, and she didn't get pregnant. Didn't get pregnant. It's disappointing. Okay, we say, well, you know, even when we're doing it this closely, let's go again. So this was done in November of 2018, and we have a holiday shutdown, and we don't get to do her until January. So in January, she has a lining of 9.2 already with a 16 millimeter follicle. We see her the next day. It's the dominant follicle is larger, it's 18.5. Her E2 is 452. Her LH is 15, so it's getting close. We triggered her, 7 days. We transferred a size 2 early blastocyst. We're running out of embryos, you can tell. We're running out of embryos.
What is the size 2?
It's small. It's small, you know. You've got, you know, size 4 is a regular blastocyst. This is a size 2. That's for our embryologist. Of course, she doesn't get pregnant. Oh boy. So now we're starting to think, well, what should we do? So we go again. She reloads. She gets new embryos. She does an IVF cycle. She comes back. This is her transfer cycle. She's 40 years old. She's got a lining of 7.3 dominant. This is a really unique situation. She has 2 dominant follicles. She's got a 12 and 11. And occasionally you'll see this. And I love these cycles because now you have more estrogen, more progesterone circulating inherently. So 2 days later, she has the follicles are growing. The E2 is 275, but it represents 2 follicles. Her LH is 7, basically. We go another day. Her lining, now her LH is 11. Her lining is 9.5. Her E2 is going up. So we decide to go another day. We want to push her. We want to see her have her own natural surge. So we go another day. Her LH is 61. And her lining is now 10 millimeters. She's got 2 dominant follicles, both about 16 millimeters. Her E2 is 723 picograms per mil. Pretty high when you think of a spontaneous menstrual cycle. And she's 40. Say that she just fits the thing. Michael and I know this because we spent our entire careers, especially when I was at Louisville, learning how to learning how to not let people ovulate. Doing all this contraception work.
Which we're going to talk about.
Yeah. Just a segue to what you're going to hear. Okay, 61 was her LH. We triggered her. She's on her surge. We think we're at the maximum level. You got a 10 millimeter lining. We're really excited. We transfer in a better embryo because she's reloaded and did another cycle with us. Of course, she got pregnant. So I love these cycles. All right, so they're flashing all these signs to me that I only got about 5 minutes to go. Go ahead.
How do you determine transfer at 6 versus 7 days? I see you going back and forth between the 2.
When the LH is greater than 25, if it's over 25, we think you're on their surge by definition, we go 6 days. If it's under 25, I used to think that if it got just about 20, it was okay, but I said, let's make sure they're really on the surge. I wait till they're 25. And then we give the HCG trigger immediately, and then we go 6 days.
Have you noticed any differences in pregnancy rates? That's 6 versus 25.
6 versus 7?
Yeah.
Depends on who's doing them, because sometimes some of our clinicians, they trigger way too early, I think. And they don't let them have their own natural surge. It's one of those situations that how natural do you want to be, And if you really want to be natural, you should probably let them have their surge and then decide to go 6 days. Because then you've got the maximum number of thickness of the endometrial lining and all those other peptides that are circulating, right? Inhibin, relaxin, everything else that's in the milieu that might be helpful. That's our argument for that.
creating the cycle. The delay of 6 to 7 days, is it like the progesterone? Is that or what's the?
So we're just kind of affecting what would normally happen. The embryo that's coming in, the blastocyst that might be coming in from a natural conception would be in the window of implantation between days 18 and 22. And so if you're doing program cycle, you're usually just going progesterone on P plus 0 that day, and then 5 days later you're transferring the embryo.
So Steve, one other quick question. What happens if you make a mistake, which I know you don't ever really do, but if you did, say she came in the next day and her egg was gone, what would you do then?
Oh, Abby Evelyn, former fellow, extraordinary REI in Nashville, who has her own podcast, author of a recent book. If the egg is gone, we cancel the cycle because we don't know where we are. And if we're really going to try to be careful about this, I mean, you know this, those embryos are so precious. Nobody wants to put an embryo in unless it's absolutely fine. And in natural cycle, it's a little bit more expensive, so it's a bigger ask not to transfer, but we don't transfer. Okay, so, all right. Let's see, Mahar, what do you want to do? I've got about 10 more minutes of slides to wrap up, or I could truncate this talk and keep on time. What do you want to do?
Now, keep it another day.
No. I'm talking about this. Oh, you're smart. That was good. Okay, thanks. 34-year-old male factor, 18 millimeter dominant follicle, E2 is 217, LH is 12. But the lining was so thin, now what's happening is we're starting to modify, quote, the natural cycle. So we give estrase. And this is just, look at the date on this. This is only a couple months ago. This is one of my patients that, we have to accept what all our colleagues are doing. I mean, we're a lot of physicians. So one of the physicians said, oh, let's just add some estrase. We gave estrase 2 milligrams vaginally 3 times a day. The problem is, if you give estrase, you're going to get a huge surge. You're going to get this huge amount of estrogen going into the endometrium. And because of that, you probably get an LH surge. Okay, so when we added the 2 milligrams and they brought her back the next day, look at her E2 level. Her E2 level is 1362. She went from an E2 of 200 to 1,362 picograms per mil. Her LH was 34. So when you give estrase and you give this huge bolus of estrogen, you're giving that positive feedback that you see in a natural cycle, and you're going to go ahead and ovulate, or at least start the process of ovulating. So she's on her surge. We augment with Ovidril. We transfer in 6 days. We transfer this male. Luckily, she gets pregnant. She barely made the endometrial lining cut off at 7 millimeters. But I always tell the fellows, and I always tell people that we're working with who's not done this, you don't want to use estrase until it's absolutely necessary, because you're probably going to get a surge. Okay, so we talked a little bit about natural cycle. An outgrowth of this is that you could use letrozole and make somebody who's maybe oligo-ovulatory natural. And so, but is that really natural? And I certainly have done this. We do a lot of people now with letrozole and gonadotropins just to give them a stimulated cycle and an ovulatory event. But why do you think the people want to do that? Why not just do program cycle? Why not just do program cycle? Why do patients not want to do that? I'm sure there's a triage nurse that knows this. Exactly. Dr. Lin, another free weekend here at the Bellagio. They don't want to do the progesterone. Nobody wants to do IM progesterone. Okay, so I'm going to skip this slide because you all know how to do how letrozole works. And I'm going to just show you this last example. This is a 36-year-old G1P1. She had a prior natural cycle FET delivery. She has a thin lining on another natural cycle that we treated with estradiol with no conception. So we said, let's make you stimulated. We gave her letrozole, and then on day 9, she has a dominant follicle that's 18 millimeters, E2 is 110. The E2 on letrozole cycles is artificially low because some women just don't recover from that block. And so lining was, like I said, 4.6 because it lags. So let's wait because of the letrozole. So she got letrozole and estradiol, and we started her back in 2 days. And actually, we knew that in 2 days, your lining was either going to be thick enough to work or not, because we knew that she'd probably be surging, and her lining was 6.8. Her dominant follicle is 23 millimeters. Her lining, her E2 again is over 1,000, and her LH is 42. So this is exactly, and again, we just did this a couple months ago. I included this in. This is the first time I've given this talk. I do anything for my former fellow, Dr. Abdallah, and put together a talk at the last minute, even though we're down to only 5 people at the office. But it's okay. Did I get a lot of sleep last night? No, because I was still working on the slides. Okay. All right. So we augmented this lady with ovulatory. We transferred in 6 days. Luckily, she's pregnant, but she miscarried. So we'll wait and see what happens when they do it the next time. Okay, so my last couple slides. So as I mentioned, there's this controversy, and we've been dealing with this for the last 5 or 6 years of, should we do natural cycle in women that are naturally ovulatory, or even make them ovulatory if they're anovulatory, just so we can get a corpus luteum. So there's a national study that was sponsored by NIH. It's called the NatPro study, where women were randomized to either 3 cycles of natural cycle or 3 cycles of medicated. And it was powered to detect the pregnancy outcome of preeclampsia. I can just tell you the final conclusion is not available, but the study, we stopped enrollment already, and we're analyzing it. But what we can tell you is that there's conceptions in both groups. It's just amazing how efficient this is. But was a huge difficult recruitment, because we would get women that would say, okay, I'll do the study, and I just hope that I get randomized to natural cycle. And when they got randomized to program cycle, they just dropped out. They said, I'm not going to do it. And this was like a huge problem. So the fear of having daily IMs, or in our case, we do IM every 3 days and supplement with vaginal progesterone, is a huge dissatisfier. So in summary, last slide, natural cycle is an option for women with regular ovulatory cycles. And you can modify an anovulatory cycle by using letrozole, but only use 1 letrozole tablet a day, because it's so powerful sometimes. These women have a real delayed response in making estrogen. And then you could use vaginal estrogen in the form of, we use estradiol tablets, but don't do it unless you know that the next day you're going to probably trigger. Just hold it off to the last minute. I mean, I have women that will do multiple ultrasounds and will wait till their follicles like 25 millimeters before we'll give them a trigger shot, because we just don't want to use estradiol, because we know if we give it to them any earlier, it probably truncates their cycle. So at this point, I'm going to close. I want to thank you for being such a good audience and, being good sports, right? When you're the speaker, you want audience participation, because it just makes everything so much nicer. So I want to thank Mahar for this wonderful seminar. Mahar, I know it's been a really tough year. I think we were all shocked and horrified about what happened to your center. I know when I heard about it, it was just devastating. To think that that could have happened to any one of us. And I got to tell you, our center has got really low security. I know we thought about it, and it's just because we wanted to make ours really patient friendly, so people could drive their car right up to our front door easily. So I know it made us really pause. I want to just thank you again for putting this on. It's been wonderful to be at every one of your seminars, and I hope that you have continued success. Thanks very much.